Welcome to the 2022 Telehealth Summit, brought to you by the California Telehealth Resource Center. Normally, I'd pause for applause there, but we'll just continue moving along. I'm Rob Kay. I'm a technical program manager with Ochin, so I run all things MyChart and Video Visit, and I'll be the moderator today. Some quick bookkeeping going on. Today's session is purely for informational purposes. The California Telehealth Resource Center has no relevant financial interest, arrangement, or affiliation of any organizations related to commercial products or services discussed during the Telehealth Summit. I always feel like we should record that and play it back at high speed like they do on the radio. And before we begin, I want to review a couple of tips for the platform. So you guys can do lots of things over here, but I think the main point is to note that any questions you have will hold till the end, but feel free to drop them into the chat, either in Zoom or in the Huava platform, and I'll kind of monitor those and assemble them and tee them up for Michael. So looking forward to seeing your guys' engagement there. So let me introduce Michael Hasselberg, who has a long, wonderful, prestigious resume that I'll highlight quickly. He's out of the University of Rochester, so full on the other side of the country for us. And he is the co-director of the University of Rochester Health Lab and the Systems Digital Health Incubator. In one of those fun lists of important people, he was named one of the top 50 in digital health by no less than Rock Health, one of the big investment firms. Especially because of his work to improve equity and technology innovation during COVID-19. So he's not just another tech innovator, he's actually looking at inequity, and for this population, that's especially important. He's been in school roughly forever. He is a board certified psychiatric mental health NP, so don't worry providers, he knows your world and your pain. He's completed his PhD in health practice research and a postdoc in healthcare leadership from no less than Cornell. And then he kept on going and works with the Robert Wood Johnson Foundation as a clinical fellow. He works with the state to help define systems. And finally, he's on the board and consulting to several digital health startups. So he is engaged across the board. And he's here to talk to us about the retail transformation and many other things. So with that, Michael Hasselberg.
Thank you so much, Rob, for the introduction. And I'm going to share my screen here. It says the host has disabled my ability to share. If someone could assist with that, that would be great.
And this is a good building of empathy with our patients who often struggle to connect, that often technology doesn't work. So really, it's just a giant exercise in empathy building here.
All right, I've got it. Pull it up here. Great. Again, thank you all for having me. I have no commercial or financial relationships that I need to disclose for this presentation. Whenever I start presentations, I always like to tell a story, and I'm going to start this story outside of healthcare, and I'm going to talk about two of the biggest disruptors in the retail industry. And it's these two gentlemen here. And I suspect a lot of folks probably do not recognize who these two gentlemen are. These were actually two math majors at the University of Michigan. And their real claim to fame was they developed one of the early expert computer systems. And really what their computer system did was able to kind of predict what buyers were purchasing, and so the retailer could get those items in faster than really anybody else. And these two math majors were Tom and Louis Borders, and in 1971 they applied their computer technology to the book business. And at that time, they opened up their first Borders bookstore in Ann Arbor, Michigan, and no other bookstore could compete with Borders. Barnes & Noble at the time could not compete, and it was because Borders had this technology to really understand what their consumers were purchasing and get those products in faster. And so if anybody remembers Borders bookstores, they were huge, massive bookstores that had a bigger selection of books and eventually other products, CDs and other merchandise that, again, no other bookstore could compete with. Throughout the 70s and 80s, Borders grew throughout Michigan, into Pennsylvania, into New York State. And then the 1990s happened. And this is where Borders kind of lost its edge and stopped innovating. And, if folks remember the 1990s, the big thing that was happening in the 90s was the internet boom. And instead of really jumping on the internet boom, Borders Bookstore doubled down on what they did best and where they were winning. And that was, having this really massive brick and mortar presence. And so what Borders ended up doing was they partnered with the Kmart Corporation. And so early 1990s, Kmart ends up acquiring Borders. In a lot of ways to Borders, it was a match made in heaven. Kmart had the largest brick and mortar retail presence in the country. Kmart had already acquired Warden Books, and so was moving into the book business. And after that acquisition, a couple of years later, the Borders Group spun out of Kmart, and Borders just really took off, where over the 90s and into the early 2000s, there were over 700 Borders bookstores across the entire world. Then, however, in July of 2011, Borders announced they were going bankrupt and were liquidating. So really, what happened to Borders Bookstore? Well, I suspect most folks recognize who this gentleman is. And, this is Jeff Bezos at Amazon. And Jeff Bezos and Amazon essentially killed Borders Bookstore. And let me tell you kind of how Amazon did this. And it was really because Jeff Bezos looked at the value chain in retail differently than Kmart did, differently than Borders did. So let's look at the value chain for books. Essentially, at the ends of the value chain are authors and readers. And, Jeff Bezos really understood that that's really the most important thing. How do I most efficiently connect my authors to readers in a really seamless way? But in the middle of this value chain, you had publishers and distributors and bookstores. And essentially, Borders was focused on the middle of the value chain. They wanted to have the biggest bookstores, they wanted to be the biggest distributor, and they wanted to have kind of the biggest brick and mortar reach. So where Jeff Bezos decided to do, if I'm going to really most efficiently connect the ends of the value chain, I've got to disrupt the middle of the value chain. So we all know, Amazon started off as an e-commerce bookstore, a book company. And in 1997, Amazon.com went live. And, at this point, you could search for books online and purchase books. But not long after that, Amazon, launched another vertical, really, launched online self-publishing. And so now, as an author, you could just go online and, publish yourself and not have to go through a publisher. And then very soon after that, Amazon launched the Kindle, which was really one of the first e-readers. And so at this point, there was never, ever a need for a reader to step foot in a bookstore again. But, it wasn't really the infusing of technology in the middle of the value chain of where Amazon is, where it is today, as really this kind of massive, innovative, disruptive company. And really where Amazon is today is because of this. It's this simple, folks. This is Amazon's patented recommendation algorithm. And this is essentially their machine learning algorithm to predict, what consumers want to purchase. And let's break this formula down. One of the really key hallmarks to Jeff Bezos and Amazon was Jeff Bezos really launched the 5-star rating system and, really collected new types of data on consumers and let consumers essentially rate those products. And having all of, again, this massive data on consumers, Jeff Bezos and Amazon was able to start comparing, consumers like me look like consumers like this this, and we rate items very similar and could really kind of understand purchasing patterns of consumers that look like each other. Then what they did was, over time, they started to understand the buying patterns of an individual consumer and could see, what did you as a consumer purchase 10 years ago? What did you purchase 5 years ago? What did you purchase, just last month and then immediately after that? And then kind of really combining these two inputs into their machine learning recommendation algorithm. This is the output. Now at the touch of my phone, I have a retail experience where I can purchase really anything I want at any time, at any place. And really the interesting thing is Amazon will make recommendations of things that I might want to buy. And more times than not, it's probably right. And something I'm going to click on. And it's items that I might want to buy even before I ever knew I wanted to purchase them. And that's really how, Amazon disrupted retail and continues to disrupt retail. And it's really, again, the data behind all of that technology. So we all know, the recent news of Amazon. I mean, they've been moving aggressively into healthcare over the last several years. And, just over the last month, the acquisition of One Medical and, Teladoc and partnering with Intermountain Health. We know that Amazon Care is aggressively coming into the healthcare space. And so health systems like mine, the University of Rochester Medical Center, where I'm the chief digital health officer, I got to be quite aware of these new market entrance into healthcare and the way, Amazon was able to really disrupt the retail industry, really understand those lessons learned and apply it into our strategy, which I will tell you about of how we're learning from what Amazon did and doing that at Rochester to hopefully provide, higher quality, better experience, low cost care to the consumers we serve. So let me tell you a little bit about where I'm from. This is a picture of Rochester, New York. When people think of New York State, people immediately think of New York City. We are far from New York City. This is city of Rochester is in upstate Western New York. We are right up below Lake Ontario. We are a city within the city confines of about a million people in from the city and the counties surrounding it. But my health system, which is in the city of Rochester, has significant reach outside of Rochester. And if you go 30 miles outside the city limits, you enter really rural areas of New York State. And, from that Lake Ontario down to the Pennsylvania border over to Ohio, that is really the primary market of my health system. And it can be very, very rural. The total market share is about 1.5 million lives that is in the primary market of my health system. Now, the things that we struggle with specifically in these rural areas of New York State is lack of transportation. And, one of the things that we have a lot in Rochester, and actually, we are very proud of actually getting an award for 2021 of being the third snowiest city in the United States, behind Buffalo, New York, which is right next door. We average over 100 inches of snowfall a year. And so you talk about lack of transportation in our rural areas, several months of our year, we are under snow. That makes receiving healthcare very difficult to the patients we serve. So as a health system, we really needed to think outside of the box to reach these patients. So University of Rochester Medical Center, overall, we are the 5th largest employer in the entire state of New York, and that includes New York City. We're the largest health system in New York State outside of New York City. And as you can see from those dots in the middle of the map, we cover a big portion of the state. We have 10 hospitals, part of our health system. And, we've got other hospitals that we're looking to partner and affiliate with at different levels of affiliation in the states. We are a true academic medical center. So we are a research institution. We, have about $134 million in NIH funding. A lot of it, we do into the technology space. And we're, as a medical center, just the medical center alone, we have about a $4 billion medical center budget. What makes the University of Rochester Medical Center different than just about every other academic medical center left in the country is there's only a handful of us that flow up to a single budget. So what that means is our health system rolls up to our undergraduate and graduate campus budget. And that is very important to know. Most academic medical centers, the health system makes money, the college typically loses money. And so most academic medical centers have broken away from their parent university and they have a separate budget than the university. We have elected not to do that. We actually lost a CEO for suggesting that we break away from our university. And we look at that as a differentiator. So how we look at that as a differentiator is we actually have a true digital health innovation incubator at the medical center. It's not a research shop. It's funded by the university. And I have faculty in our School of Engineering and Computer Science, Data Science, even our School of Music and Business School under the same roof as clinical faculty across all of the different service lines in our medical school. I have faculty from our nursing school. I have faculty from our dentistry school in this incubator. And we do several things as an incubator. We onboard promising startup companies around the country that align with our health system's strategy and vision into our health system ecosystem. But we also build technologies, and we don't build technologies for the hope of spinning out companies and getting rich. That is not a KPI of what our incubator does. We build technologies to meet our health systems needs and improve the patient care of the patients we serve in our community. And we're more likely than not to open source our code and give away our technology than we ever, think of, trying to commercialize it. So let me talk about, applying what we've learned from retail to healthcare. And let's, again, go back to the value chain. So when you think about the value chain in healthcare, you've got clinicians and patients at the end of the value chain. And in the middle of the value chain, you have health systems, insurance companies, and employers. And at the University of Rochester, we are, again, a health system. We're self-insured for our own employees, and we're also the largest employer. And very similar to Borders, and actually very similar to most health systems in the country, where we are focused is at the middle of the value chain. And so for us, traditionally, we're focused on mergers and acquisition and building new ED towers and orthopedic buildings and growing. And it's not been at the ends of the value chain. But this makes sense because, our health system is predominantly fee for service. And the way you win in fee for service is winning that medical loss ratio game, where essentially, our insurance companies, we know, are trying to get as much money as they can from employers in our region and including us, and they want to pay out as little claims as possible. And then as a health system, that means we need to bill as much high cost procedures as we can, knowing that we're going to get denied on a lot of those claims so we can, get claims reimbursed and make our margins. And it's, kind of totally backwards on where we should be focused. So, where we're trying to disrupt is, again, doing what Amazon did with the value chain and really, again, focusing on the ends of, at its simplest, healthcare is all about how do I best connect those clinicians and healthcare providers to our patients. And the way that we're doing that is disrupting the middle of the value chain. And how we're doing that is on the health system side. We have a pretty well thought out digital transformation strategy, which I will walk you through and talk to you a little bit about our successes and how we think about digital transformation in our health system. And then on the other side, as we learned from Amazon, yes, technology is important, but even more important to that is the data behind the technology. And, we're again disrupting on that more insurer and employer side, and actually, the health system in general, based off our data strategy, which intertwines with our digital transformation strategy. So let's start with our digital transformation strategy and how we're doing it at the U of R. So when we think of digital transformation from a strategy lens, we really break it up into 3 buckets. Our first bucket is really focused on access. And, we define that access as our digital front door. That is what we've been working on for really the last 2 years. And we've kind of really exclusively honed in on our primary care network and have started to expand off of that into urgent care. And now we're expanding that into our specialty services. And I will tell you on a slide here in a minute how we conceive the digital front door and what we're doing. This whole thought of the access is how do we engage our consumers using the current technologies that they own in a convenient way to access our providers within our health system. The next part of our strategy is really now focused on engagement. And we're currently setting up the governance structure to be successful in the engagement part of our strategy. And this is around the concept of, okay, we've onboarded patients using technology into our health system. How do we keep them engaged in care, not only in care in our health system, but engaged in health promotion and wellness using technologies? And we know that this part of our strategy is going to require a lot of different virtual modalities. And so I'll talk to you about kind of how we're thinking about what those modalities would be and how we're going to be able to manage all of those different virtual modalities within our current technology stack. And then the last part of our strategy is, really this idea that in the access and engagement parts of our strategy, we're going to be collecting lots of new data on our patients that we have not otherwise, up to this point collected within healthcare. And how do we take that data? How do we aggregate it in one place? So essentially, our enterprise data warehouse strategy. And then how do we leverage things like data science and machine learning to develop our own, recommendation algorithm where we can essentially match the right patient to the right level of care at the right time in the right place. And we're building the foundations where we can truly reach value-based care and become what we consider a smart health system. So, starting with the digital front door and, the full disclosure, my health system is an Epic shop. That is the electronic health record we use. And, that is what we use as the foundation of our technology stack. And so when I say that, if Epic has the functionality or will have the functionality and it's good enough, it doesn't have to be the best technology solution out there in the market. And there's lots of them that for certain functionality are a lot better than Epic. But if Epic's is good enough, we're going to go with Epic every single time because that is, the interface that we want our providers interacting with, and it's the interface that we want our patients interacting with. But the problem with Epic is, a lot of areas of functionality they aren't there yet, or it's not on their roadmap. And that's where we have to kind of think outside the box and either look for solutions that we're going to purchase or we're going to build ourselves. Getting to that front door, one of the things that we knew our consumers wanted was the ability to schedule online, to really have that open table type experience into our health system. But the problem we had starting off was the data on our end of who our providers were, which insurances they accepted, which types of subspecialty patients they did best with, what languages they spoke, was not up to date, was housed in various different areas, and it was a mess. And we knew if we tried to push out online scheduling with our current messy data, it wouldn't be successful. It would be a bad experience for our patients, and we would get a lot of pushback for our providers. So to fix this, the first thing we did was we stood up a chatbot on our external website. And this chatbot did several things. It served as, essentially a virtual patient care assistant, helped you answer frequently asked questions. How do I pay my bill? But really what we wanted this chatbot to do was to understand how was our patients searching for our providers? What was the terminology that they were using when they were looking for, let's say, a back pain specialist? And so we got that data, and we wanted to see what was our data producing back to those consumers as the results. And we knew right off the bat that we were going to get it wrong more times than not because our data was a mess. But this allowed us to understand how our patients were searching for our providers, and then we leverage our clinical informaticists across our health system to quickly go into our data and clean up our data on our providers. And this really set us up for success. The last thing that this chatbot did was encourage our patients to sign up for MyChart, which is the patient portal for Epic. And we got our MyChart penetration in the last 2 years up from 30% penetration up to 90% penetration in our specifically our primary care, where we focused our digital front door. And it wasn't just this chatbot that got that penetration up. There was other strategies that we did, but that was really important. We needed to get patients up on our patient portal. The next thing we then did for our front door was we stood up online scheduling. And again, we started in primary care, in which we then quickly expanded out into our specialists in our health system. And so now, even if you are a new patient to the University of Rochester, you have never seen any of our providers, you can see which primary care providers are accepting new patients and actually, just at a click of a button through open scheduling, schedule right into that provider's schedule. And that was, again, a big win actually for our patients, but it was also a big win for our providers. Despite their initial hesitation and resistance to this, it actually gave them more flexibility in their schedule. So we've actually found it to be a win on both sides. From the open scheduling, we then moved into what we call e-check-in. And so, what this is and how we define this is the ability for our patients to essentially give us their insurance information, their demographics, fill out all of those patient questionnaires that in my health system, we were doing still paper and pencil when patients arrived, or spending a lot of time with our nurse that's essentially checking the patient in, collecting this data, and then manually inputting it into our electronic health record. We essentially turned on the e-check-in functionality in Epic for our MyChart patients. And we put all of that, again, check-in information right on into this system. So now our patients could check into their appointments, receive a text message before their appointments, reminding them to check in before they ever arrived. Now, we still know that there are patients that we did not have up on MyChart, and some of those were some of our more high volume clinics. And so what we did in those cases was we stood up kiosks and allowed patients to check in on the kiosk, but with the plan that we're going to put these kiosks out of business. So at the end of that check-in on the kiosk, we encourage patients to sign up for our patient portal, so then they can check in on their own device before they ever arrive at that next appointment. From there, we moved back to telemedicine. And I know this is a telemedicine conference, and I'm going to tell you why I say we moved back to telemedicine. So like every health system in the country, when COVID broke out, we needed to turn on telehealth for the entire health system in essentially a week. Now, we have a long history, a proud history of doing telehealth in pockets well before COVID. Our behavioral health, pediatrics, and neurology have been leaders in telehealth for years. But, the majority of our health system was not doing telehealth when COVID hit, like most health systems. And very efficiently and quickly, we stood up telehealth, where we went from doing 2% of our ambulatory volume as telehealth visits pre-COVID to 90% of what we were doing essentially within a few weeks of telehealth. And that was it perfect? No. Was it seamless for our patients and providers? Absolutely not. And the one thing that we learned was, with our current integrated telehealth platform within our EHR, it was not suitable for doing what we call on-demand telemedicine, where, a patient, I have a minor urgent care issue. I want to see which providers are available now. I want to select that provider and see that provider right now. And, and really the ability to do e-visits. Those were functionalities that we didn't have. We had to build them out, and we had to partner with, a best of breed telehealth platform to serve as our essentially on-demand retail. We also moved into kind of the retail side of telemedicine in our health system. And then again, from there, the last part of our digital front door was what we call our express pay. And this is the ability for our patients to start having price transparency, pay their bill with a click of a button on their own devices, or just kind of swipe their credit card at that kiosk when they arrive. And so that is how we conceive our digital front door. And we've been able to successfully stand this up in primary care across our entire health system. Over the last couple of years, we've now again moved into urgent care, and we're targeting, based off of our data, certain specialty practices that we're rolling out this functionality to. So what we're getting prepared for now for the next couple of years in our strategy is really that patient engagement, and how do we going to keep patients engaged using technology. And as I said, this is probably going to require lots of different virtual modalities to accomplish this. The one thing that we don't have at the University of Rochester is we don't have endless technology resources, and the IT shop at our system is stretched very thin. And so the idea of having to build integrations into Epic for lots of different point solutions it's just not reasonable or feasible, even with new Fire APIs into the EHR. And so the first thing we needed to do to kind of set the foundation for our patient engagement platform was we partnered with a best of breed vendor to essentially serve as our power strip. And what this means is, as a health system, we only have to do one integration. We do the integration into this power strip, and then all of those different point solutions or digital modalities that we want integrated into our EHR so we can prescribe them out, and then the data collected on them flow back into our EHR is all handled by that power strip and that vendor. And so some of the modalities that we are starting to stand up and what we're plugging into this power strip include things like digital care pathways, example, pre and post-op care pathways, where we shoot out SMS text reminders of upcoming appointments and provide education and collect patient-generated outcome data, through these care pathways, and then, triage and a triage up or triage down, based off of how patients are moving through these pathways. Things like digital education, pushing out videos of our education to patients to their own devices. Those are things that are very piecemealed in my health system. We want to centralize that and to be able to give that patient a kind of a single patient education digital experience. Things like prescribing mobile apps that we've built ourselves to address behavioral health issues, to other wellness and chronic disease mobile apps. Things like prescribing rideshare, Uber and Lyft visits to our patients right out of the EHR. And then, of course, remote patient monitoring. And so, we're setting up really our governance around this. We do a lot of these different things in silos, but we're really organizing it and getting it into kind of that omni-channel experience platform. The last part of our strategy is really the data piece. And, let's talk about data in health systems. So what I know currently about my patients is really what's in the EHR. And the EHR has things like, did a patient arrive to an appointment or not arrive to an appointment in their scheduling history? It has a list of medications the patient may or may not actually be taking, and that list is typically not, reconciled as often as it should be. It may have a list of conditions that this patient may or may not have had in the past. I have vital signs and labs and imaging. That is in the EHR, and yes, it's a mess. That is what we have access to. But things like patient experience is not in our EHR, and those things are siloed out in our health system in essentially another data mart. Things like social determinants of health, we're starting to get those integrated into our EHR, but typically that data has been siloed out. Financial data, claims data, different silos, our quality data, resource management data, supply chain data, even our pharmacy data and our market analysis and strategy data, all in different silos. And so, as I said, one of our big kind of pushes and in parallel to our digital transformation strategy has been our enterprise data warehouse strategy. How do we start breaking down all of these silos? How do we start putting all of this data in one place? How do we start defining this data the same way? Length of stay is differently defined by my clinicians, differently defined by my operational people, different definitions by my quality people, and different definitions by our payers. And so how do we align the definitions for all of our data fields? And we are actively working on our enterprise data warehouse with hopes that we will become a smart health system. But to become a smart health system is not going to be that easy. And, I want to talk about another retail focused company that was right in our backyard. And, this company was IBM, and its, home is Binghamton, New York, less than 200 miles from the city of Rochester. And IBM has had some of the most brilliant data scientists in the world that worked for that company. And heck, in 1997, their Deep Blue, essentially AI program, beat a master chess player. And then, less than 15 years later, IBM's Watson, won in Jeopardy. And this was in 2011. And then, right after Watson won in Jeopardy, IBM made some audacious goals of really trying to transform healthcare. And, they partnered with some of the biggest institutions in our country, like MD Anderson Cancer Center, and they made goals of we're going to eradicate cancer. We're going to use AI and machine learning to predict cancer and deliver the right treatments at the right time and essentially eradicate cancer. And they invested $4 billion in buying as much healthcare data as they could get their hands on. And we all know essentially what happened with Watson Health. It wasn't successful. And, they recently ended up being sold to a private equity firm at pennies of the dollar and have just kind of spun out of that firm as a Watson Health 2.0, but to date they have not been able to be successful. And so let me tell you about how we're preparing ourselves to become a smart health system at Rochester. So like Amazon, we knew we need to do a better job of profiling our patients. And one of the things that we're really proud about at Rochester is we are the home of the biopsychosocial model, which is this, hallmark model in healthcare that says that you can't just define a person by their medical elements or their biological needs. That, you really, to address healthcare, you need to think about, social aspects of a patient. And we now know that, social determinants of health are, a primary thing that we're thinking about in healthcare, but also, brain health and psychological health. And so what we did at Rochester is we said, you know what? We need to start somewhere. Our EHR data is a mess. All of our data is in silos. We don't really know our patients. We don't know who they are. And we need to collect better data on our patients and ask those right questions. But where do we begin? And we said, we're going to go back to our roots and we're going to start, understanding our patients through these biopsychosocial domains. And so as a health system, we made a strategic decision about 7 years ago to essentially leverage the NIH's patient-reported outcome initiative, where essentially they wanted to take static psychometric tests, apply computer adaptive and item response theory to those tests to more efficiently collect data on those traditional scales faster and quicker and with more accuracy. And so we started launching promise instruments in these broad domains of emotional wellness, social wellness, physical functioning, and pain interference on every single patient in our health system. And so essentially we started in orthopedics and we expanded out from there. And if you arrived to my health system, you got handed an iPad of a system that our innovation incubator built. We collected these promise instruments in these broad domains. And it didn't matter if you were coming in for a toenail injury, we were going to ask you about your mood. And again, we collected all of this data, we integrated it all into our EHR. We made very nice line graphs for our clinicians to see how patients' physical functioning and pain interference correlated with their mood and perceived social functioning. And now we have the largest patient-reported outcome data set in the entire country. And this data set is systematically collected on our patients in these broad domains. And that is what we use as our foundation for really all of our machine learning projects that touch our clinical service lines. So we use that data set as the foundation, and based off the question we're asking, we will pull in other data variables, either from our enterprise data warehouse that's being formed or those various data marts to answer those questions. We've had a lot of success with this. And to give you an example, one of the early value-based reimbursement mechanisms that my health system wanted to dip their toes in to get experience in was joint bundles. And those of you who are not familiar with joint bundles, the concept is, you would get a capitated rate from the time of a joint injury until the time you were able to efficiently or effectively rehab that patient. And so before we started dipping our toes in those joint bundles, our leadership came to our innovation incubator and said, hey, can you tell us what the most expensive part of a joint bundle is going to be? And we looked at our data and we said, yeah, it's getting placed into a skilled nursing facility after surgery. That's the most costly part. And then our leadership said, okay, can you predict pre-surgery which patients are going to most likely be admitted into a skilled nursing facility? And we leveraged that PRO data set and we pulled in other variables. And, we were able to build that prediction model with pretty high accuracy. And what we built in our EHR for our surgeons is what you saw on the right-hand side of the slide was essentially these speedometers. So it gave our surgeons the information, hey, if I was to cut today, there is an 80% likelihood that this patient is going to get placed into a nursing home. This surgeon could then do simulations in real time in the patient's record. Well, what if I was able to lower the patient's weight? What if I was able to get social supports or visiting nurse services set up with this patient pre-surgery? And they could see that dial move and make better decisions around who I cut and who I don't cut. And actually, the biggest kind of, variable that predicted skilled nursing facility placement was the level of perceived social support in the home pre-surgery. And so, this really, not only saved my health system lots of money, this prediction model, as we moved into joint bundles, but it just delivered better patient care. We cut on the patients that needed to be cut at the right time. And we kept a lot of patients out of nursing homes that if we cut too early, would have been higher likelihood been placed in a nursing home setting. So other ways that we're leveraging this data, is we geocode all of our patients in our health system, and we overlay, our social determinants of health data. We overlay the mood scores and pain interference. And, one of the things that we found out during the COVID pandemic, specifically around telehealth, was, where we made the biggest impact as we were looking at our data at around the end of this COVID pandemic, starting to dwindle down around July of last year. We needed to start making a value argument so we could negotiate with our local commercial payers to continue paying for telemedicine at parity after the pandemic ended. We wanted to get our ducks in a row. And what we found was that it was our Medicaid patients that actually did the best in terms of engaging in telehealth and having, really good outcomes. We're really excited to say, this data, what I'm talking about right now is going to be published in the New England Journal of Medicine, Catalyst. It's going to be coming out next month, and it's really, as far as we're aware, like the first real, data set, of large data sets to show that, telemedicine is cost effective, at high quality. It won't be abused by providers if paid at parity. And we're excited, and with the biggest impact being on the Medicaid population. But what we also learned was it was the Medicaid population not only that engaged in our health system the most and had the best outcomes in telehealth, but they weren't engaging via video. It was mostly telephonic, and it wasn't because we didn't have internet access out in our rural counties. Our governor actually invested a lot, and our previous governor and current governor has invested a lot over the last 10 years of getting broadband out across our state. So there is internet out in these rural areas. But the problem is that we found, looking at our social determinants of health data, is, the internet that these Medicaid patients rely on are the data plans of their essentially cell phone providers, and because they can't afford internet into their home. And we all know if you're trying to do a video conferencing feed to a cell phone working off a data plan, it's going to kill essentially that patient's data plan, and hence why they weren't engaging via video on their cell phones. And so let me kind of tell you, how we're thinking outside of the box of, addressing this, and, my thoughts of, where the biggest disruptor may be in healthcare over the next several years. So again, looking at those geocodes, where our patients could get telehealth if they weren't doing it on their own phones was if they wanted to see a specialist, they could go to their primary care offices, and we could bring in telehealth into those primary care offices, or even some of our community outlining hospitals. We also kind of stood up multi-specialty telemedicine suites in a lot of our rural primary care practices. But what we found, looking at our data, that 70% of our patients live more than 10 miles away from the closest U of R primary care practice. It did not get any better for our urgent care practices. Again, about 75% of our patients live outside of 10 miles of an urgent care practice. Here is what I think is going to be the biggest disruptor in healthcare, and where we can better meet these patients. When in July of 2021, Dollar General came out and said, We are hiring a chief medical officer, and we are getting aggressively into healthcare. That to me was more disruptive than anything Amazon is doing or Walmart Health is doing. And let me show you why. In my market, 85% of my patients outside of the city live within 2 miles of the closest Dollar General. So we know our patients are going to Dollar Generals to get their food, to get their clothing. And what a better place to essentially address healthcare and engage our patients is when they're on their daily life journey in Dollar Generals. And so if anybody knows Albert Wu, Dr. Wu at Dollar General, love to have you advocate that University of Rochester would love to partner with Dollar General. That being said, I have talked to Dr. Wu. He's still new to his position. He's still kind of figuring out what their healthcare strategy is going to be. But this is a prime opportunity. The last thing I want to talk about here is where we see the future of healthcare going. One of the things that we're proud about at Rochester is our proud history in VR. And actually, VR is a strategic priority at our university. And part of that reason is we're an optics town. We were the home of Eastman Kodak. So we have a proud history of doing engineering and optics. And, a lot of our optics engineers actually get hired by the big VR companies like Meta to build those headsets. So on our university side, we have a big investment in VR. And on the healthcare side, we do a lot in the VR space. And we see VR as a potential another modality that we can reach our patients in a more immersive way beyond just two-way video conferencing. So in our incubator, we've built, our own VR applications that we have live in our hospital in dentistry and pediatrics to reduce opioids and sedative medications. We've hacked into the headsets of Oculus. Our signal processing engineers have used those sensors in the headset, and we can calculate heart rates and respirations just from the headset alone in real time. We've got some patents behind that with hopes that we can take VR to the next level and actually adjust those environments based off patients' own biometrics. We've partnered with other leading VR companies around the country to test their VR technologies in our system. And I'll show you a brief demonstration of a use case of a very simple application we built for our pediatric population to reduce opioid sedative meds. And I'm going to play a short video here, and then I will be done and open for questions.
Even though he is wiggling around a lot, he is still very interested in what is going on in the video, and he's not hitting. He's not, as you see, he's tapping it, but usually he'd be trying to bite and smack everyone else. Are we all done? Or do you want more? Do you want more? Okay, put it back on.
Thank you.
And it's very easy for him, usually with his grasping, it's hard to use anything. Mm-hmm. So with the cushion, it's very textural, easy on his face. Huh. And like I said, he usually is trying to go after whoever's trying to do any sort of procedure on him.
Yeah.
So he's more into this than what's going on with his body.
It's very interesting. Thank you.
You're welcome.
All right. So with that, I'm going to stop my share, and I'm going to turn back to Rob, our moderator. If there's questions that I can answer in the last 7 to 8 minutes here.
You bet. Thank you, Michael. And I invite people to drop questions into either chat. We're keeping an eye on them. But I'm going to just selfishly sort of take first stab at it. And first, thank you for the presentation. Covered a lot of ground from Borders, which I remember fondly as the go-to choice for birthday presents in the early 90s, to, and as the MyChart guy at Ochin, hearing that you guys went from 30 to 90% adoption. I have a whole lot of questions around that, but we'll leave that to the side. And finally, it seems like one of your big points is around when we think about the retail revolution and what we can extract from it. Your big point was data. Data can then power predictive tools. And that's how Amazon won. And so I'm wondering if you can sort of double click into that again and talk about, you showed briefly that dashboard with the speedometers in there, but I know you guys are an Epic shop. So are there tools you have found to be especially effective? Where do you see that data road taking us in the next while? And sorry, one last caveat. A lot of our customers here serve the underserved, multilingual, low income. You touched on the sort of access to technology being a challenge. So how does that population that is truly a minority fit into your data use? Because they aren't the most common one.
So both excellent questions. So for us, we're not ready yet to kind of fully roll out, artificial intelligence and machine learning in our health system. I mean, every day I'm getting phone calls from AI vendors and new companies that they've got the solution to my problem, which most of the times, like, it's not even a problem that I have, but they say I need to meet with them because they've solved kind of the ills of healthcare using machine learning. And, I am really tough with machine learning vendors and AI vendors because, I say, no, you haven't. And why you haven't is because we have terrible, terrible data in healthcare. And, it doesn't matter what algorithm you build, it is, it's going to be garbage in, and essentially we're going to get garbage out the other side because our data is a mess. And so for us, it has been really thoughtful of, how do we collect better data? How do we clean our data up? How do we better profile our patients? And really, again, investing in that enterprise data warehouse so we can be successful for applying machine learning. Some of Epic's own machine learning tools that are in there, that have shown some success in like sepsis and others, we question, whether or not how accurate they are. And then the other cultural change management thing we have to deal with is, our providers, aren't yet ready for machine learning making recommendations on things like this patient may have sepsis. So, really working on that change management operational workflow. So for us, it's collecting better data, cleaning our data, identifying where the gaps of our data. That's where we're making our most significant investments. So we'll hopefully have the foundation to be leaders to becoming a smart health system.
That makes sense. I've heard it said that healthcare is 5 years behind banking and 10 years behind travel. So
it's more
Expedia and whatnot.
Way more complex, right? To build a digital twin of a patient is very different than building a digital twin of an airplane, and knowing when it's going to arrive and when it's going to depart and, wind speed and all that kind of stuff. Like, healthcare is just way too complex. And anybody who says that they have the solution and answer, I would tell you to be pretty hesitant and look at that, because we saw the story with IBM, which it was in our backyard. And IBM had a lot of money and a lot of data science expertise and bought a lot of data and wasn't able to make it successful.
So it sounds like the takeaway is invest in that entry level, that foundational layer of data. And then, so pulling over from the chat here, my potentially distant cousin Mendy asks, how is patient engagement being impacted by language and literacy and technology literacy? I know you touched a little bit on the future of Dollar General, but how are you seeing your engagement adjust to your different populations?
Well, interestingly, and I think it's what a big myth is, our low socioeconomic patient population, our underserved patient population, doesn't have access to technology, doesn't understand technology, and it's actually, we found the exact opposite. These patients all have a smartphone, and they're probably more reliant on their smartphone than other of us that may be weller off or higher educated. And so we're looking at the smartphone as really being that great conduit. We're looking at Dollar General as just being, along that journey that a patient travels every day, where we have Wi-Fi access and we can, put healthcare services in that Dollar General. Things that we're struggling with around kind of literacy and languages is we have a very high deaf population in Rochester, New York. And RIT, our Technology Institute across the street, is like the leaders for the deaf population on the academic side. So, we're really trying to partner with our RIT colleagues to understand how do we make this technology compliant for our deaf population, and that's been difficult to overcome thus far.
Got it. Well, we have a 1-minute warning, so we're gonna do a 3-question lightning round. One is Elias asks, can we do a strategic alliance with your healthcare org? Yes, no, and how can we reach out?
Reach out to me. I'm on LinkedIn. Yes,
Great.
Healthcare is all about partnerships. So please, yes, I would love to partner with anybody.
Perfect. Next is from Lindsay. When you are published, can you let the resource network know so that we can share it out?
Absolutely. We got 2 telehealth articles coming in the New England Journal of Medicine in the same issue, which we're very proud of. That is, they have 2 telehealth articles from the same institution coming out. We'll share both of them.
Got it. And finally, you may not be at liberty to say, but what tool were you using for that power strip?
Zelf. It's comes out of Providence Healthcare. They built it. So yes.
Well, great. Thank you, Michael. Thank you for those great answers, taking us journey from borders to data to VR and just really identifying where Amazon's coming for us and how we can help. Mandy, to clarify, that was Zelf, Xealth, like health, but with an X. God bless startup lingo. And with that, thank you so much, Michael.
Bye, everyone. Thank you.